kort sagt kan man säga att det finns väldigt stora utmaningar inom diabetesvården. Sen finns det väldigt stora möjligheter också.
Men nu är alltså det internationella perspektivet och det är erfarenheter från USA det handlar om. Med oss från Boston, ska vi lägga upp honom i bild, har vi Robert Bob Gabbay som är doktor och som sedan 2013 finns på Harvard Medical School där han är ledare för diabetes, obesitas och teknologi. Han pratar inte svenska som jag, och hör han då småländska så kanske det är ännu värre. Så att vi vänder oss till Bob och säger Welcome Bob, so nice to have you here on the screen. We are, after only Swedish speakers, very eager to listen to you. So please Bob, go ahead and share your thoughts. You have the stage all by yourself.
Thank you so much, and I appreciate the opportunity to speak to you all. And I'm sorry I can't be there in person, but I think this is a really important topic. And I've been asked to give a bit of the U.S. perspective on the broad sort of area, so I'll do that over the next 15 minutes, and then we'll have a few minutes for questions and answer. This is just a brief sort of who I am kind of thing. You can see my various work experiences that I've had, some of the training, and then some fun facts about me that perhaps as we do question and answer, you can follow up on if you like. So, when we think about diabetes more broadly, a few things that I would say is one, it is incredibly common. 38 million people living with diabetes in the US, about 1.5 to 2 million of those have type 1. And the numbers unfortunately continue to grow at a significant rate with over 90 million people with prediabetes. It is costly. It is 1 in 4 healthcare dollars spent in the US every year. So this brings a lot of attention to ways to improve care. And given that most of the cost of diabetes is related to its complications, if one delivered better care for diabetes, we could really save a lot of money. It is a very data-rich disease, probably more so than any other chronic condition I can think of, and therefore really lends itself to technological solutions. It is increasingly recognized that it's heterogeneous. Type 2 diabetes is probably more a broad definition, and there are various subtypes that are being defined within that broad group. And type 1 certainly in the the early stages is also heterogeneous. And this lends itself to a more personalized approach to the management as we gain a better understanding of the heterogeneity. And most importantly, it is incredibly burdensome for people living with diabetes. Anyone, and perhaps some of you in the audience have firsthand experience. I certainly do through the patients I care for at the Joslin Diabetes Center. It is quite a challenging disease to have with estimated 180 decisions a day that need to be made around their health. And it's also burdensome for healthcare professionals because the tools are not in place. And it is complex and has gotten more complex. The number of different treatment options has really expanded dramatically over the last 10 or 15 years with some 15 different therapeutic options at any given time. And so all of this lends itself to a potential solution. Sadly, if you look over the last decade in the US, the quality of care is measured by the percentage of people that achieve a healthy goal for A1C or blood pressure or cholesterol has really not improved despite all of the new therapeutic options and technology that has come to bear. Uh, and I would say it's technologically friendly. People living with diabetes have really adopted technology at a pretty rapid rate compared to some other chronic illnesses. And that community is quite empowered, as I'll talk about in a moment. So, broadly speaking, if we think about the care delivery of diabetes, for that 38 million people living with diabetes, there are only 3,500 clinically focused endocrinologists serving them. They end up caring for less than 10% of people. So when you think broadly around uh, type 2 diabetes, certainly, but to a certain degree, type 1, it's largely a primary care disease, and it's managed by primary care physicians and nurse practitioners in large part. So any solution that is aimed at improving the broad level of care really has to address those clinicians in particular. And the challenge of those clinicians is, numerous. One, they have less than 10 minutes typically to see a patient living with diabetes. There are multiple morbidities, not only in terms of diabetes, having hyperlipidemia and hypertension and a wider array of illnesses that need to be managed. Now, liver disease being an important one added to the long list. But those individuals at, primary care clinicians are caring for the whole person. And so they also have to deal with back pain and asthma and a variety of other things. So, really quite challenging. The documentation and the documentation tools are very onerous. The electronic health records are cumbersome. They lead to, and I see patients and use Epic, which is the largest electronic health record in the U.S., and I'm constantly struggling with. My eye contact to the screen versus my eye contact to the patient. And so this is a big challenge. And then the knowledge explosion with all of the complexities and new therapies and new comorbidities associated with diabetes really exploded. And it's very difficult for them to stay up on not only diabetes, but of course, all of the other diseases that they have to manage. Um, the other trend that I think has really influenced diabetes care significantly is patient-driven care. Uh, there's a wonderful book written by Susanna Fox called Rebel Health, and it really chronicles this movement of patient-driven care and devotes a fair amount of time to diabetes because I think that is an area where this has happened quite significantly, and particularly in a movement that was coined as "We Are Not Waiting." Uh, this began over 10 years ago, and it started with a group of individuals living with type 1 diabetes or having family members uh, who were technologically savvy and said, wow, there are insulin pumps and there are continuous glucose monitors, again, in an earlier iteration of them, but why can't we have them talk to each other? And so they started to hack into those devices, develop algorithms, uh, and there were many people that were using these algorithms uh, in a freestanding open source system. And again, some of you in the audience may have been the adopters of this. Really quite remarkable if you think about it compared to other chronic diseases. And to their credit, uh, they ended up pushing the FDA towards earlier approval of automated insulin delivery. The first Medtronic 670G was approved based on what you might argue is a relatively small number of individuals in a trial for something so revolutionary that used, in essence, AI to manage their diabetes. And to their credit, they also ultimately did a randomized control trial published in the New England Journal of Medicine, and ultimately getting FDA approval for their algorithm. It's quite an incredible story for patient-driven diabetes care. So now there are so many sources of information that are being or can be fed into the individual with diabetes that all of this digital exhaust becomes potentially overwhelming. And again, this is an opportunity to manage that data more effectively, not only for people living with diabetes, but also for the clinicians they take care of. So I think there are a number of trends that play to the advantage of artificial intelligence stepping in. One, the expanding population and complexity of diabetes, uh, the shortage of healthcare professionals, uh, not only for endocrinologists, but also there are not enough primary care clinicians available. And they are all burning out on the amount of data and information that's coming in. Uh, there at the same time, patients are driving healthcare and rightfully asking for more, which just puts more on the system, and they want to have their data. Uh, the use of wearables are exploding, not only continuous glucose monitors, but activity measures and a variety of sleep measures and all sorts of things. And this is only increasing. And, certainly this is happening to a great deal in the US. And then the challenge of managing all of that digital exhaust in an effective way to take data and move to insights. And then finally, the promise of precision medicine to be able to personalize care for the various subtypes of diabetes, the way in which people live their lives. AI certainly has an opportunity to do that. So, AI to the rescue. And a few areas where we're already seeing this happen is on the healthcare professional side. There's a lot of effort aimed at efficiency of care, and I'll talk about that in a moment. Uh, there are tools that are looking at data analytics and decision support, taking that data, analyzing it, and then making recommendations. And 1-2 Analytics is an example of that. And then on the people with diabetes, efforts to reduce the burden of the disease. Um, this idea of just-in-time information. So, for example, at Jocelyn, where we care for our 25,000 patients, uh, you know, we utilize diabetes care and education specialists who provide all sorts of useful information for people with diabetes. But the challenge is, and a good example is sick day rules, what to do if you're sick and how to manage your diabetes. Well, it's great to get that information at a clinic appointment, but really you want to know that the moment you wake up with a fever and don't remember what they told you to do. You need that just in time information. And again, AI is great for that if using appropriate sources of information to create the AI tool. Uh, and then contextual nudges, being able to nudge individuals at the right time for information or guidance that could be helpful for them, and then ultimately to personalize that care as it gets to know the individual, to personalize those recommendations. And we see examples of these, but we're still in the early days. So there have been some very big bets on AI. So if you look at investors in terms of the investments in AI in digital health, there's been almost $6.5 billion the first 6 months of this year invested in AI tools, uh, and that interestingly, if you look at in that investment in digital health companies, two-thirds of it practically are for AI-enabled startups, and that's really where the investments have been. Uh, when you look at within those AI startups, where is that money going? More than half of it is really around workflow and efficiency, and really we're just starting to see the investments. In ways in which not only around efficiency of care and the workflow issues, but more importantly, from my perspective, is really around the care opportunities, which I outlined in the previous slide. So, what's the regulatory environment in the U.S.? And I would say this is what we know now. But as you know, the U.S. is in the midst of I don't even know how to describe the madness that happens. A tweet could change anything at any moment. But that said, um, the FDA has embraced AI tools, and interestingly, there are over 1,000 FDA-approved AI tools or devices already. That has exploded dramatically. Uh, 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 with very few back in 2022, and over the last 2 years, this has risen dramatically. The vast majority so far are in the radiology world, which does intersect in diabetes, as I'll mention. But really, we're just at the beginning of this in terms of what's happening relative to the world of diabetes. So, what about in diabetes? Uh, well, retinal imaging systems have been FDA approved and are increasingly being used to be able to read those retinal images for retinopathy screening. And that has the promise to really improve care because less than 50% of people living with diabetes get a yearly eye exam. We know if they do and get appropriate treatment, we largely could prevent blindness. Yeah, diabetes continues to be a leading cause of blindness in the US. Uh, Interestingly, there was a request for information by the FDA to ask how AI could help in diabetes detection, since we know that more than 90% of people with prediabetes are not being diagnosed. About a fifth of people with diabetes, type 2 diabetes, don't know they have it. So, could AI help there? And as I mentioned, we'll call the do it yourself algorithms uh, have been improved, and there's more work being done around how to streamline that approval process. And the messages that one receives from the FDA are that they are interested in partnering and identifying ways to increase the adoption of AI tools. The soil is there. They're willing to approve things. There's huge investments in companies to do this, in venture capital and private equity to fund these initiatives. And there are many use cases in diabetes, as we just discussed, where AI could be really effective. Uh, so, what will it take for commercialization and adoption as all of this is happening? Because, as you can appreciate, getting regulatory approval is only one step in a long journey. And certainly in the US, it starts with payer engagement. And so, Center for Medicare and Medicaid Services, which provides insurance for those over 65 and those of low income through Medicaid. They and private insurers are beginning to reimburse for AI supported care, specifically retinopathy screening, as I mentioned, in diabetes, and also a remote patient monitoring. There are now codes that are being reimbursed for looking at, for clinicians to look at CGM data, for example, and make adjustments in insulin dosing. Although they're really underutilized, it's estimated less than 5% of those that could benefit are using it. Workflow integration is particularly challenging. Having the algorithm is one step, but incorporating it into the workflow of primary care nurse practitioners is an important aspect, and demonstrating return on investment is going to be critically important for adoption. So what do I see happening in the near term horizon, let's say the next 2 years or so? I think we're getting closer to a fully closed loop system that doesn't require meal announcements. There are several trials going on. I would estimate within the next couple of years we'll see something on the market. Chat boxes to coach people in an increasingly personalized way. They already exist. I think you'll see more of that. Decision support tools for clinicians to guide them on, for example, insulin adjustments, medication changes. There's the early stage of that, but I think over the next couple of years, you'll see others on the market and being used. This idea of creating a digital twin from all the information available in the electronic health record, and then being able to, in real time, test different interventions to see what might be most effective in a personalized care. I think we have some examples of that. I think you'll see more of that. And then finally, efforts to improve the workflow both for clinicians and patients to reduce the burden of caring for diabetes. I hope will accelerate very quickly. So as I say, I think you can see how AI really has the opportunity to solve a lot of the problems associated with diabetes. It being common, early diagnosis, prevention efforts, costly, reducing the cost of complications with better care, managing all of that data effectively, taking that data and turning it into insights that are actionable. With the heterogeneity of diabetes to truly personalized care, and hopefully reducing the burden and ultimately making the disease less complex with the tools that are available. So the last thing I'll say is this vision will only be realized if there are partnerships, the type that you're building in Sweden, where I think we can learn a great deal of, bringing together industry, government, regulatory, people living with diabetes, clinicians, NGOs. I think there's great promise for people living with diabetes. And with that, I hopefully have a few minutes for questions, and thank you so much. And I hope in the future I can join you in person and continue this discussion. So thank you so much.
It's easier if you see the audience.
Oh, nice. Yes, thank you. Yes. I'm glad to see that there's an audience there.
Yeah.
Good.
They have been listening carefully, Bob. We are running out of
Even though
time.
just speaking to you is always a joy, but still.
We love to see you smile and we love to listen to you. We are running out of time, so we say thank you for taking time, and we'll just move on here in Stockholm. And anytime you're here, I'll take you to Franzén.
Sounds good. Thank you. All right. Take
Thank you so
care.
much. Dr. Bob.